5, 4, 3, 2, 1. Let's go. Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi, and welcome to Diary of a Kidney Warrior podcast. I'm your host, Dee Moore. Today's episode is something a little different. Not only is this a filmed visual edition, but it's also completely listener-led. This means that every question I ask today was sent in by you, the Kidney Warrior community. This builds on an important conversation we began in episode 142, Breaking the Silence, Menopause and CKD. And I'm delighted to be joined once again by menopause specialist Dr. Vikram Talaulikar, who answers all the questions you sent in. So whether you're watching or listening, thank you for joining us. Hi, and welcome back to Diary of a Kidney Warrior podcast. How are you doing today, Dr. Vikram?
I'm fine, thank you. And I hope you're doing well too, Dee.
I'm really good. I'm really excited about our interview today. And today is not just an audio interview, but it's a visual interview. So the listeners will be able to sit with us and see us as we record this interview today.
That's wonderful.
The other thing that's different about this interview today is that you, the listener, are in complete control of the questions that I asked Dr. Vikram, because today is a listener-led episode. So all the questions that I will be reading out today were sent in by you, and I'd like to thank all of the listeners who sent in their questions for me to ask today. So thank you so much. Before we begin, I have to start with a disclaimer because we cannot give medical advice on the podcast. We can give you generic advice and we can signpost you to your renal team. So for everyone out there, this is not medical advice. This is for educational purposes only. So after saying all of that, I'm going to start with the first question. And the first question, the person wanted to remain anonymous. Anonymous listener question number 1 is, how can I restore my hair growth and thickness?
Okay. It's a question probably for me as a hormone specialist, but equally for a dermatologist. So I'm going to do my bit in terms of hormones. If we look at it from a perspective of menopause, early menopause, premature menopause, or natural menopause after 45, the drop that happens in hormones, estrogen specifically, does mean that it can contribute to scalp hair loss. Equally, some women may note that they have chin hair or body hair which increases. And that's because the body is sensing your estrogen level is going down in perimenopause, menopause. Relatively, the androgen levels, the testosterone levels, are a little bit slow to come down. So there's a bit of relative excess of androgens. And that's what causes the scalp hair thinning. Sometimes chin hair develop and hair on the body may come up. Now, in terms of the scalp hair, if you did have access to and wished to use HRT for menopause symptoms, that would help. So estrogen is good for hair, good for skin. So if you did go down to using HRT after balancing risk benefit and it's right for you, that would help with hair. There are other conditions which can also contribute to hair loss. Like, for example, if you're low on iron, low on ferritin, stored iron, you have thyroid issues where you're hypothyroid, low on thyroid function. There can be other mineral vitamin problems, especially the ones which are often flagged up are vitamin B12, folic acid, as well as zinc. So we often say, try and see your GP or your primary healthcare physician so they can look at all these minerals, vitamins, iron, thyroid levels. They may refer you to a dermatology clinic if it's something more than that. From hormone perspective, HRT or estrogen replacement, if it's right for you, will also help with the hair.
Thank you, Dr. Vikram. The next question, the person wanted to remain anonymous. So anonymous listener 2 asks, someone with CKD that is doing dialysis and also has liver disease, can they have HRT or non-hormonal options like, and they've named the medication. I know that you know which one it is, so I'm not going to read the name of the medication. And what options are there?
Okay. So you certainly can use HRT. Hormone replacement therapy in the modern times is available in forms such as, say, transdermal patches, gels, spray forms of estrogen. Also, you have a patch that incorporates the progestogen. You have other forms, for example, you can have intrauterine coils. So there are many forms which tend to be non-oral. And traditionally, people were worried about having HRT with complex medical conditions like renal conditions or liver condition because the oral medication used to go through the gut, get metabolized in the liver. That's when sometimes there could be problems. Now that you can bypass the liver, even if you have CKD, renal conditions, liver issues, as long as you have stabilized them, so the active condition is being treated, you're now having stable monitoring levels of function with the kidney and the liver, you can certainly have hormone replacement therapy. So you can talk to your gynecologist, hormone specialist, renal team, they can liaise. What they will try to do is give you the safest form, which doesn't increase risk of blood clotting or problems. They will try to give you the least dose that's effective for your symptoms, so not too much. Because often with renal conditions, you need to adjust the dose of any medication. In terms of the non-hormonals, currently the NK3 receptor antagonist, the novel medication like fezolinetant or alizinetant, they haven't been tried in patients with severe liver conditions or renal condition, so they remain contraindicated. So if you look at the contraindication list of these medication, it will say contraindicated in severe liver or renal problems. So at the moment, we can't recommend them. Perhaps in future, there may be subsets of women with stable liver issues and stable kidney function where we may be able to use these as non-hormonal option. But you can certainly use other off-license non-hormonal option. For example, antidepressants, SSRIs or SNRI, with the dose adjustment, sertraline, fluoxetine, venlafaxine. These also impact hot flashes, night sweats, anxiety. They can make these symptoms better. So you have other non-hormonal options and HRT as your main treatment options for menopause symptoms.
So there's a lot more options there than the person may have originally thought. So yes, anonymous listener number 2, I hope this helps. The next question comes from Lisa, and she asks, how do I tell the difference between menopause symptoms, CKD symptoms, or medication side effects?
This is a very, very good question. Sometimes even difficult for us as healthcare professionals to accurately distinguish between what are the symptoms of CKD, what is perimenopause, menopause, what about all the other background medical issues and medications. If your symptoms have started at a certain time where you expect menopause to happen, so let's say for most women that will be early 40s, late 40s, early 50s. If you've noticed symptoms changing or appearing which change to your menstrual cycle, that's a typical indication this is more likely to be menopause. So let's say you were having regular cycles or a particular pattern of cycles, menstrual cycles before, and that changes and brings on some symptoms. That's more likely perimenopause hormone symptom. But of course, there will be symptoms like fatigue, there will be symptoms like mood changes, there will be symptoms like brain fog or joint pains. These are very non-specific, anxiety, and they may just fluctuate over time. So sometimes it's almost impossible to know, is this all this that you're going through with the CKD management or background life issues, or is this something new that's actually the menopause is causing this? And we often say, try and monitor symptoms over time, maybe 3 months, 6 months, 9 months. And usually you will come to a point where you will say, actually, symptoms have changed. I used to feel like this before the last 6 months. And I certainly feel something new has happened. which is causing these symptoms to be more or less. Sometimes it goes to the point where we offer hormones or a medication as a trial of treatment for menopause symptoms. So we may say take a short course of hormone replacement therapy for 3 to 4 months with a minimal dose of safe hormones and see what happens. Because if it's hormones, your symptoms will respond, then you can continue the HRT or non-HRT medication. On the other hand, you feel no different at all, even with the introduction of small dose of hormones. It's unlikely it's the menopause causing those symptoms, and it's all to do with the CKD or background life and work issues that's impacting you.
Thank you again, Dr. Vikram. Lisa, I hope this helps. The next question comes from Suzanne, and Suzanne asks, why does the menopause cause itchy ears?
So menopause in general can cause lots of skin issues. We don't know the exact mechanisms why that happens. It's believed that the skin becomes more sensitive. A lot of women report new onset of eczemas, rashes, skin itching, or a sort of ant crawling sensation under the skin, nighttime pruritus, often sometimes with hot sweats and itching can go together. Typically, behind the ears is not very specific of menopause, but of course, we're all individuals and we might find that itching affects one particular part of the body more for somebody than the other. And so you can be more sensitive to rashes itching in menopause. You can also have histamine sensitivity, which goes up. So a lot of women start reporting sensitivity to certain foods, certain products, because their histamine is increased. One would give a general advice as to avoid anything that you think you may be allergic to. Make the area of the body very clean, dry. Make sure it's not getting sweat accumulation. In terms of the specific ear itching or behind the ear, do see your GP or a physician because it could be a local cause. Sometimes we think it's menopause, but it could be something local, very specific sort of itching or rash that may be happening for non-hormonal reasons. Otherwise, the sort of treatment here would be antihistaminics or local ointments or lotions, which you might be prescribed by your GP. And that's probably going to be the treatment suggested there.
Thank you, Dr. Vikram. Her next question is, does CKD affect timings of menopause?
Yes, and I think we covered this in the last podcast, isn't it? We talked about how each one has an influence on another. So having CKD can make you more prone to go through menopause below 40, premature menopause, again, slight increased risk of early menopause between 40 to 45. Although we don't know the direct mechanism, it's thought to be all the body changes that happen with a chronic condition like CKD, and also some immune processes that may be involved behind, which impact the ovaries. Equally, menopause, because of lack of estrogen, which is thought to be a very renal protective sort of hormone, can accelerate CKD. Once you go through perimenopause, menopause, early menopause, it can accelerate changes that happen in the kidney as part of the CKD process. And therefore, you may need more intervention, more treatment at this point. So there is a link in observational data which does suggest it can influence timing of menopause. And that's why there is so much awareness now needed to make sure that women know this could be a possibility. Healthcare professionals consider this, often unknown in the healthcare professional scenario.
The next set of questions comes from Sally, and Sally asks, will the perimenopause come on quicker for me?
It's a similar sort of answer to the last question, is that we know that if you have CKD, there are some changes in the body, the stress levels in the body, the immune changes that may be happening. We do see an observational data association with CKD and early menopause. So if you're heading towards early menopause, early natural menopause, then generally the perimenopause will be pushed early. So you may start noticing changes to your periods, some of the menopause symptoms earlier in life. That's true.
The next question is, will my medications for CKD impact any hormonal therapies that I might be able to take?
Almost all medications can impact each other, but generally we look for very specific, any problematic interactions between medications, like one reducing efficacy of another. If you had menopause symptoms, and if you had background renal condition or other metabolic problems, hypertension or diabetes, you will always be prescribed in the modern times what we call as transdermal estrogen, which means estrogen given through the skin rather than an oral tablet. You will often have a combination progestogen, which will be either given through the skin or as a uterine coil, or as an oral capsule, which is much more milder form of progestogen or progesterone. And those don't seem to impact most of the other medications. Now, of course, there can be interactions with thyroid medication. There can be interaction with a few other medications in general. But per se, there is no problematic interaction. Like we used to say when in olden times, women were prescribed the pill for everything, even for menopause. They used to get the contraceptive pill. That's a very strong hormone because that can impact how other medications are metabolized in the body, how effective they are. But the modern HRT is more physiological, more natural, given through the skin. It doesn't directly impact many of the medications you will be receiving as part of your treatment. So you can safely have it alongside.
The next question is, what is the osteoporosis risk and steroids?
So that is a particular concern in CKD because we know that in the background, of course, having CKD, having the medication, having immune-related medications like steroids, all will increase risk of osteoporosis or osteopenia, bone loss mass. And often there'll be lots of lifestyle intervention, vitamin D supplement as needed based on the levels, the calcium intake to be kind of taken care of. And then, of course, exercise is always good. Any weight-bearing exercise is excellent for bones, but there can be limitations with exercise. So in terms of the hormones per se, having early or premature menopause below 45 significantly increases risk of osteopenia or osteoporosis because estrogen is a bone-building hormone. For women, it's really important they get good bone mass, and that usually starts building around 20s, 30s, after which it will peak and then come down. So if you've gone through menopause earlier, then what happens is you can have lack of hormones for a while, which would then mean those many number of years without estrogen, the bone mass will start going down. So we don't want that. So if you have early or premature menopause, one of the things you will always be recommended is to replace back the estrogen. Try and get the estrogen back on the board as HRT if possible so that we can protect you against the bone loss. If estrogen is contraindicated for any reason, HRT cannot be used, then there are non-hormonal options for protecting bone. For somebody who goes through natural menopause, let's say after 45, so not early or premature, again, as estrogen levels come down, the bone density will drop. So that's additional over any background risk you have. And so we'll always be saying, try and optimize your lifestyle within the limitations as much as you can, because if the levels keep falling more and more, and we'll often be offering you bone density because you've got additional risk factors, the bone density will tell us on the scan how much bone is being lost, how much bone loss has already happened. Then we will recommend some form of hormonal or non-hormonal treatment to prevent osteoporosis or treat it. So it's a very important factor when CKD and menopause both exist.
Her next question is, will menopause affect my blood tests for kidney disease and obscure any disease progression?
No. So menopause per se won't affect your kidney disease bloods. And in fact, remember, even for menopause now, unless you're going through a premature menopause below 40, we don't even recommend measuring hormones. We go by clinical diagnosis, symptoms to offer somebody menopause treatment, especially after the age of 45. Menopause per se won't affect your blood test that you do for kidney function, CKD per se. And again, the menopause won't obscure how you progress through in terms of the response to medication, the CKD course per se, except that we feel that estrogen is a very renal kidney protective hormone. So if you have CKD and then you start going through menopause, especially below 45, it may be that the course of CKD may wobble a little bit. You might need more help, more intervention, more treatment because you're losing the protective effect of estrogen as you go through menopause. How much impact? Perhaps little, not huge impact when you go through menopause, but it's important to be aware because if you're aware that this may be menopause happening and it may slightly rock the course of CKD, then you're better prepared. You're going to be having that monitoring, having that intervention quicker. Equally, if you're starting to have menopause symptoms which were being attributed to CKD, and people are thinking, why are you not feeling better? What is this fatigue? What is this brain fog? And then you might realize, okay, it's menopause happening side by side, and they treat the menopause, you will feel better. Then you won't have unnecessary intervention for CKD. That's the rationale in terms of it won't obscure the disease process, but it will have some influence on it because both will run together. And it's important to keep an eye on both side by side.
Her next question is, how could I change my diet to reduce impact on my kidneys during the menopause?
So there's no specific menopause-related advice in terms of diet. Just like we would advise a healthy diet for somebody who's non-menopausal, it would be similar principles even if you're going through menopause. Few important bits to remember is eating healthy, a bit of Mediterranean type of diet, small portions at a time, not too big portions, enough intake of vitamin D, calcium, protein, and again, discuss that with a nutritionist or a dietitian or your renal team to make sure what your requirement is, because everyone's will be slightly different. And then making sure that goes hand in hand with good exercise. So healthy diet, exercise, nothing fancy. That's really what we are concentrating on.
And her final question is, what exercise could I be doing to ease my symptoms?
Again, I can't be prescriptive because it's really how much you can do. People will have different thresholds, how much exercise they can do. There may be limitations with mobility. Again, the kind of standard advice is 30 minutes a day for 5 times in a week. Whether you enjoy brisk walking, whether you enjoy running, whether you enjoy doing Pilates, yoga, sort of exercises when you're sitting down, pulling, pushing things. Weight bearing is very good for bones. So if you can manage weight bearing, that's the fantastic exercise. Other than that, do something that you enjoy because many of us start exercising and then lose the will along the way. So make sure it fits in with your routine, either morning, evening when you enjoy. Listen to music, watch TV if you can. And then along with that, try and concentrate on getting those 30 minutes. Whatever physical activity you can fit in that will always help.
Thank you, Dr. Vikram. The next question comes from Gilletta, and she asks, why do ladies on hemodialysis not get cycles? And why, for some, don't they restart when transplanted? And she adds that she's been in menopause since 36 years old.
Yes, it's again a very good question. So usually when there is hemodialysis, what is thought is that the mechanism why periods stop is slightly different. It's something called as hypothalamic suppression. It's not always the menopause. Because remember, menopause means the ovaries stop making hormone. There's nothing wrong with the brain. The brain tries to stimulate the ovaries to make hormones, but the ovaries don't respond. They don't make any estradiol, estrogen. That's why you go into menopause. But here it's a little bit different. It's the hemodialysis, the stress that's associated with it, the changes that happen in the body. There are certain changes in the urea, creatinine levels, the whole environment in the body. There may be changes to prolactin hormone. And all that means is there is suppression of what we call as a GnRH that comes from the hypothalamus, which is part of the brain. So the body stress while the person is going through the hemodialysis stops pulsatile release of a hormone called GnRH from the brain. That stops release of 2 hormones, FSH, LH, in a pulsatile way from the pituitary gland, which is behind the nose. And because the brain is suppressed, it's not stimulating the ovary to produce the hormone. And that stops the periods. So it's temporary. The ovaries are fine, They're not being stimulated by your brain hormones because the FSH-LH is low. And often once the treatment is complete or you have a transplant or often there is change in the treatment regime or the situation changes, you find that the brain suppression disappears. The GnRH comes back, the FSH-LH hormones come back, start stimulating your ovaries, and you have return of periods. So that's a temporary suppression, not menopause. If you've gone through menopause at 36, then that would be what we call as premature menopause or premature ovarian insufficiency. So you must see your general practitioner or your renal team or a hormone physician because there is a lot you have to consider in terms of protecting your bones, your heart, your quality of life. So I hope that you are under a team that's looking at your hormones side by side with CKD.
The next question comes from Helen, and Helen asks, is there a contraindication to kidney patients having HRT?
No. As we, I think, answered for the second question, today's modern hormone replacement therapy is very safe. We give transdermal estrogen through the skin rather than oral tablets. We have got body identical or better natural forms of progesterone, which don't tend to be thrombotic or blood clotting risk inducing. So they are much safer than some of the older oral synthetic hormone versions, which we had 20 years ago. However, of course, we need to individualize. There may be certain medical pointers in someone's history, which may mean you use the lowest dose, make sure it's effective, or a type of hormone combination which is better for that person as compared to another one. Any blood clotting risk, any cancer risk needs to be factored in when making a decision. So everybody's need is a little bit different, and what HRT may suit one person may not suit another. But as a general principle, almost all or most women with CKD can have HRT without a problem for the right indication to treat menopause symptoms. And if it's early, then to protect the bones and the heart.
Our next question is, does CKD worsen any symptoms of the menopause?
Yes, a little bit like we said before, they can overlap. I wouldn't necessarily say worsen, but they kind of both happen together, and that's why you might find they are a bit more noticeable or severe if they were just happening because of one reason. Say fatigue, brain fog, weight gain or loss. Sometimes things like brain fog with often memory changes can happen. Things like joint aches, muscle pains, soreness, things like lack of motivation. All of those sort of changes can headaches, migraines. Those sort of symptoms can be non-specific, could be also attributed to CKD and a number of medications and medical treatments, but equally menopause can bring them up. So if you're having it for both reasons, you're going through the CKD treatment, but equally then menopause starts and brings these on top of the CKD, you will notice them more often. You'll find they overlap and sometimes become more severe. So herein again lies the importance of looking after your body's signals, monitoring your symptoms. When did I see them becoming more severe? Have I noticed a change in symptoms? Is it correlating to my periods? Am I at an age where I think this is perimenopause, so maybe something additional is happening? That sort of monitoring for 3 to 6 months will make it clear that there's a more likely hormone symptoms on top of your CKD.
Thank you, Dr. Vikram. Julie asks, could my CKD have been caused or exacerbated by endometriosis or the early menopause resulting from the hysterectomy I had to have at 36 years old?
Not directly, but there could be some indirect background pathology that may be existing. So we know endometriosis is often linked to immune causes. There may be some inflammatory immune changes in the pelvis, in and around the pelvic tissues, which often are implicated in how endometriosis or why it develops as an inflammatory condition. And that condition could equally be responsible for the CKD and the changes in the body that have happened. If you have an early menopause, as we said before, you lose estrogen early on in life, and it could have some impact on kidney function, not directly again. Not all women with early menopause may have CKD, But if you have a background tendency or a reason or some immune inflammatory pathology that's already causing kidney damage, lack of estrogen may accelerate that process for some women. And so, although I would say directly not that it would have influenced your journey, there could be some indirect mechanism behind or impact where the two processes may have come side by side for you. Endometriosis, treatment, early menopause, and the CKD would have influenced each other.
Our next question comes from Dee. I promise you, it's a listener named Dee. It's not a question from me. And she has the question about fibroids and how these could impact menopause and CKD. So I've kind of summarized the question because there's quite a lot of detail. And as we said in the beginning, we cannot give medical advice. But in terms of fibroids and how these could impact on menopause and CKD, how could they?
Yes. So fibroids often are common when somebody reaches the age of 40, 45, 50, and that's exactly the age often perimenopause. Menopause will impact most women. Fibroids can be very small. They may not cause any symptoms. For others, they can be quite big, may press on the bowel, press on the bladder, cause heavy menstrual bleeding, very painful, heavy bleeding, push them into anemia, which can be a problem with CKD already. And so there is need to treat fibroids effectively because you don't want somebody to bleed, and become very anemic and go through all the pain and the heaviness of the bleeding. Equally, you need a definitive treatment because if fibroids are big or multiple or they're inside the womb cavity, they can continue bleeding. So someone's menopause may get delayed because the fibroids are bleeding quite often and frequently. People can take various medical treatments. And I think one of the listeners suggested that they had been given a treatment like GnRH agonist to stop their bleeding. It's one of the medical treatments that people can get. People can get hormones like progesterone. A coil may be inserted if there are small fibroids and the cavity is not very big. They may be given the GnRH analogs to stop bleeding temporarily, like induced menopause. They may be offered operations like a myomectomy to remove the fibroid or a hysterectomy to remove the womb. There are various ways of managing fibroids. I think it's important to say everybody's treatment will differ based on what their age is, what their fertility aspirations are, when have they actually entered perimenopause or menopause, what are their medical risks for a surgery or having certain forms of hormones and medicines. So it's difficult to kind of give one advice for everybody because you'll have to see your gynecologist, see your hormone specialist, liaise with your renal team, depending on what is safe for you. But generally, the advice here is that once you go through menopause, because you're not making your own hormones, for many women, the bleeding will stop. But if you have big fibroids, it will take you time because the big fibroids won't stop bleeding very easily in the early perimenopause or menopause. Also, if you don't go on to have fibroids and then have HRT, fibroids can grow very small, little by little, 1 centimeter, 2 centimeter a year on HRT because you're giving back hormones. So it's important that if you have big fibroids, you have scans regularly in menopause when you're on HRT. So both in terms of the treatment of fibroids and HRT, best as an individual to approach your gynecologist and the hormone specialist and do what is right for you and discuss all the treatment options.
Thank you so much, Dr. Vikram, for answering all of the questions. This, everyone, was our listener-led episode. Every single question in this episode was chosen exclusively by you. And I'm going to leave the final word with you, Dr. Vikram. And so my final question is, what is your final word of encouragement for the listeners?
So thank you, Dee, again for making this happen because this is really important in terms of raising awareness and helping people. So thank you for all that you do in this space. The only advice or sort of point to take home from me would be we still have lots more to know about CKD, menopause, hormones. Little bit of research exists, but we need much more especially in women who are from ethnic minorities, women who are not often frontline in research. So if you get chance, if somebody is doing research, my plea to you is participate in that research, because we really want to know from people going through these conditions how menopause can impact them and what can be beneficial. Secondly, a lot of symptoms of CKD overlap with menopause, as we've discussed in these two podcasts. So if you have symptoms which you think may be hormones, don't worry, see your GP, see your health professional, ask your renal team, could this be hormones? Could I have a consultation or be referred to see a menopause specialist or even a women's health GP, where they may be able to dissect a little bit more of your history and offer you with very simple solution, not just hormone replacement, but there are other non-hormonal therapies or treatments which you can access. So don't suffer in silence. If you think something is not right, then just seek an opinion.
And that brings us to the end of this listener-led edition of Diary of a Kidney Warrior podcast. A huge thank you to Dr. Vikram for sharing his expertise, and thank you so much to everyone who submitted a question. If you found this episode helpful, please share it with someone you know. Subscribe and leave a review so that others can find this podcast too. If you haven't already, please be sure to listen to episode 142 for the first part of this discussion. Until next time, take care and choose to live.